vascular. This patient was so happy that I had found a diagnosis. She hugged me, she wept. She said, I don't even care if it's cancer or whether there is a diagnosis. I'm just so happy that we have a diagnosis because people thought I'm imagining this pain and I was actually suffering. What I noticed was that it wasn't adherent to the uterus. So I kept asking her, have you had previous surgery? First she said no, and then she said, actually I've hidden this from the family. I did have a previous surgery, and that is why I realized that the rectal DI was actually not adherent to the posterior wall of the uterus. Now, another very important feature that could indicate bowel DI is sliding sign, and we check sliding sign is basically to see the bowel sliding behind the uterus. We see it in the upper portion of the uterus and the lower portion of the uterus. This is called low rectal sliding sign, low sliding sign, and high sliding sign. And this is how it appears. You put your probe in the anterior fornix and you push on the uterus, and can you see the bowels sliding? The bowels are sliding smoothly along the posterior wall of the uterus, telling me that they are not adherent to the uterus. So I'm pretty sure that this patient is all good. She doesn't have bowel DI. In contrast, this was a patient where the ovaries were normal. Okay? But when I tried the sliding sign, the bowels were just not moving. So when you put the probe in the anterior fornix and it doesn't move, the second thing you can do is take your free hand, not the hand with the probe, and push on the uterus and see if you can move the uterus a little and see if you can get the sliding sign. So you see, this is my hand, I'm pushing really hard, but there is no sliding. The bowels are getting compressed, but there is no sliding. The ovary was also adherent, and in this patient, I followed up the anterior muscularis because there was no sliding sign, and you can see here there was a DI nodule of the anterior muscularis. This patient had presented with dyspareunia. She had multiple scans before she came to me. All of them were normal, and we found this lesion and she was very relieved. Whenever the sliding sign is absent, it implies that the bowels are adherent to the posterior vaginal fornix and uterus, and this has a very high LR, likelihood ratio of 23.6 for rectal DI. So if you don't see sliding sign, observe carefully, there is a very high possibility that this patient has rectal DI. Then moving on from bowel DI to vaginal DI, here you see my probe is in the posterior fornix. What do I see? I see a thickened posterior vaginal wall. This is the cervical canal, that is the uterus. My probe is in the posterior fornix, and in contrast, look at my probe. When it is in the anterior fornix, the vagina is so thin and narrow. So there is definitely a problem here. That was a vaginal DI lesion. Most vaginal DI lesions are secondary to rectal DI, so it appears like a recto-vaginal DI lesion. This is the normal recto-vaginal septum that is hyperechoic, but in the area where the two communicate, you will see a breach in the recto-vaginal septum, and the rectal DI is communicating with the vaginal DI. Now, whenever we see vaginal DI, recto-vaginal DI or cervical DI, what we do is enhanced ultrasound by putting some amount of gel into the vagina, because gel causes a passive dilatation of the vagina and produces a standoff. So I can see lesions. Otherwise, the structure lesion is so close to the probe that we cannot visualize. So here you see I put in gel into this patient. I'm slowly entering the vagina. This is the cervix. Can you see? That is the posterior fornix. This is the anterior fornix. You see there's a normal thin anterior vaginal wall. When I go posteriorly, the gain is too much, so I reduce my gain. I'm looking at the posterior vaginal wall. On the left side, it's okay. But as I move to the right, what do you see over here? You get a very thickened, heterogeneous vaginal wall in contrast to the left side. And can you see these hyperechoic spots? This is what I was telling you. These tell me likely some endometrial tissue is sitting in there causing chronic hemorrhage. It was vascular, it was communicating with the rectal DI behind, so this was a recto-vaginal DI lesion. On transverse section, anterior wall of the vagina is normal in the anterior fornix, but when I go to the posterior fornix, on the left side the vaginal wall was normal, but on the right side there was this large vaginal DI lesion. So you can look at these lesions very well using gel. Now, uterosacral DI is actually very common, but it's difficult to pick up. Why? Because uterosacrals are not structures that we normally visualize on normal ultrasound. Secondly, most often they are a part of the DI of the rectum and other structures, and therefore you cannot identify them separately. And if they are seen separately, they're usually very small, and therefore they're not easy to identify. So what is the trick? You put your probe into, whenever you want to see anything in the posterior compartment, you have to put your probe into the posterior fornix. So I'm sliding my probe into the posterior fornix, and then you start identifying the layers. This is the normal vagina. Beyond that, this hyperechoic line is the peritoneum of the pouch of Douglas. This is the anterior muscularis of the rectum. There's a small rectal GI lesion there. And how do you identify the uterosacral ligaments? You see this hyperechoic band that is radiating out from the posterior part of the cervix or the posterior part of the uterus. That is the right uterosacral. I go on long section, I go as far away as I can on the right side. I don't see anything much over here. I come back to the midline. Again, you see the small rectal GI lesion. And I'm focusing over here to see, again, this is the left uterosacral. As I begin to see, I see this hypoechoic lesion. Can you see? I'm seeing this this is my probe, this is the vaginal wall, this is the peritoneum just above it. You see it over here. So remember, just above your probe and lying within this hyperechoic tissue, it is well seen because the surrounding tissue is hyperechoic and the lesion is hypoechoic. But you know the uterosacrals come out laterally. So when you see it, what you need to do is, you need to rotate your probe a little so that you see the length of the uterosacrum. So here you see, I'm rotating my probe. Now can you see, I can see the entire length of this uterosacral DIE lesion. It is heterogeneous. Like everything else in gynae, you measure this lesion in 3 orthogonal dimensions. And here you can see this is the lesion showing poor vascularity and of course diffuse borders, and it appears heterogeneous. And she may complain of pain. Now let's move. I can hear someone talking. Can you please not talk for my sake? Here is the patient with a unicornuate right uterus and a non-communicating left horn. Whenever the left horn doesn't communicate, the problem is that you will see, very often you see adenomyosis over a period of time because blood cannot come out of the cervix, so it gets retained in the cavity, and these endometrial tissues tend to get pushed towards the myometrium, and therefore you see adenomyosis of the left horn. But what drew my attention is this little tuft of tissue over here, which was seen anterior to the adenomyotic left horn of the uterus. And on zooming in, I realized it was a hypoechoic, diffuse, heterogeneous lesion, continuous with the adenomyotic myometrium, showing poor vascularity. And this was any guess? Bladder DI lesion. Perfect. This was a bladder DI lesion, and this is how it appeared on 3D. You can see it bulge into the endometrial cavity, into the bladder. Remember, bladder DI is underdiagnosed. In most of my patients, they come with history of recurrent UTI. They go pillar to post. Again, I get UTI. Again, I do a urine test. Again, they put me on antibiotic. I feel a little better, but again, so they come with history of recurrent UTI, and they're often missed because their symptoms are like that of UTI: dysuria, urgency, frequency, suprapubic pain, vesical tenesmus, incontinence, hematuria. All these are features of urinary tract infection, so they get missed. But the trick is you must observe these patients with a partially full bladder, even on transvaginal scan. And because I do a transabdominal scan, in every single patient I will obviously see a lesion in the bladder. And in transvaginal scan, you should also observe, when you're searching for bladder DI, make sure you do it at the end of your transvaginal scan. So I call a patient with a full bladder, I assess her completely, I ask her to empty her bladder. When I'm doing transvaginal scan, I look at the bladder portion at the end of my scan, by which time it will have partially filled up. Bladder DI seems to originate from adenomyosis of the anterior uterine wall, as we saw in our patient, or in the cesarean section scar, because at that time some endometrial cells get deposited in the utrovesical fold, and they may be continuous with it, like in our patient, giving it an hourglass appearance. Now this was another patient. I'm giving you this example only so that you know how a bladder DI lesion. With a full bladder, it sort of gets flattened. This was a patient with previous cesarean scar, and you can see in the area of the scar and below you can see this lesion, just like a flat tissue line in the utrovesical fold. But a transvaginal scan, you can see its typical globular appearance. This is the bladder, this is the DI lesion in the wall of the bladder, and that is the uterus. It's actually continuous with the uterus here. In this area, you can see the uterine wall and the bladder DI is continuous with each other, and again it shows poor vascularity and is heterogeneous. So this is how bladder DI lesions typically appear. Moving on to endometriosis affecting the ureters, it can be directly involved or secondary because of fibrotic retraction, which is more common than direct involvement. And here you see a patient with the right-sided hydronephrosis. She had a stent, and its stent is not like a permanent solution. Many of these stents leak. They have repeated problems. Here was another patient. Again, you see over here, her left kidney was completely gone. It had become non-functional. This is because she had a large parametrial GI lesion. Some of these GI lesions are so large, they are continuous with the uterosacral, the rectum, they go into the parametrium up to the lateral pelvic wall. Can you see the ureter? It was completely narrowed over here because of pressure from this firm, large GI nodule. Then we move on to superficial endometriosis. So far, we always thought we cannot pick up superficial endometriosis, but there's a lot of study now coming up which shows we might be able to pick it up. Here you see this patient had fluid in the pouch of Douglas because she had ovulated. This is a secretory endometrium. What you see is along the peritoneal surface, we have asked to concentrate for hyperechoic projections, hypoechoic small areas, small cystic areas along the peritoneum, flimsy adhesions and peritoneal pockets. So this was a patient. Here she had come for infertility with a secretory endometrium, and when I observed carefully, you could see these lesions. Can you see the irregular surface? Both in the peritoneum and along the serosus surface of the uterus, there are flimsy adhesions, there are peritoneal pockets. Can you see these peritoneal pockets? And all these are supposed to indicate superficial endometriosis. In fact, the new kid around the block is sonopodography, where they put saline into the pouch of Douglas through the uterus, like saline infusion. They put fluid into the pouch of Douglas and then they observe the pouch of Douglas carefully for all these features. And of course, I think more prospective studies will help us to know really if we can pick up superficial endometriosis well. Now, I've finished the 3 types of endometriosis, but I want you to note that there are certain features that may not be endometriosis by themselves, like the sliding